I have no relevant financial disclosures, but I should say that I am going to be including some off-label discussion of pediatric stroke treatment. My name is Christine Fox. My training really is as a child neurologist and also as a vascular neurologist. I was really excited to be invited here to speak at the SVIN annual meeting, and so I first wanted to start by saying how much I appreciate being here. I think it's a real signal of the way things are changing and an interest in a real collaboration between multiple fields for treatment of pediatric stroke. So just to get a sense of the room, who here mostly is treating adults or doing diagnostic angiography in adults? Most people? What about children? Who sees children in the room? Okay, some degree of children. Who's interested or are worried they might see a child show up? Okay. So there are lots of indications for neurointerventional radiology in children that are similar to adults. And I wanted to start by just a brief introduction with vein of Galen malformation, really because I view this as historically one of the pediatric cerebrovascular diseases in which treatment really has been revolutionized by endovascular treatment. So these are, as most of you know, critically ill newborns who have congestive heart failure, pulmonary hypertension, and a lot of them would not survive out of the neonatal period without endovascular treatment. And really in the modern era, the survival and the neurological outcomes of these real critically ill newborns has really changed. And in my experience in taking care of these infants, I think it's become really apparent to me how important a real multidisciplinary collaborative effort between pediatric neurologists and neonatologists and our neurointerventional team is important in getting these outcomes. So, and I bring that up as just an introduction of where I think that a real collaborative effort has made a huge difference. And in the same way, I think we're really poised to make a huge difference in terms of treatment of ischemic stroke in children. There are about roughly 3,000 to 5,000 children in the US annually who present with a first-time ischemic stroke. And those numbers probably don't seem large when you think about the number of adults with stroke. But I would argue that this is really significant if you think of the number of years that children, healthy child, will move forward having to live with a cognitive or physical disability. So just again, another show of hands. Who here has been asked to evaluate for a large vessel occlusion in a child? Value treatment. So everyone here. So this is something that is really, truly relevant. And the door really opened in 2015 when the updated ASA guidelines suggested that endovascular therapy with stent retriever may be reasonable for some patients who are less than 18 years old. And this was really revolutionary as a statement from the ASA because prior to that, any hyperacute stroke treatment for children was not something that was recommended outside of a clinical trial. But as we all know, the devil is in the details. Like, what is the patient selection for this? So there was a updated scientific statement in 2019 for the management of stroke in neonates and children that offered some additional guidance on criteria that we should be thinking about when we're considering thrombectomy in a child. But what they also acknowledged was that most of the data that we have for this really comes from adult studies. And there are many, many questions that remain in terms of pediatric patient selection. And I'd like to just touch on a couple of those today so that we can think about those together moving forward. So the 2019 ASA scientific statement says that the size of a child should be one thing that we consider when we're thinking about embolectomy. Makes sense, but then it really raises the question of how big are children's arteries anyways? So for people who are mostly treating adults, how comfortable are we in treating a child? How do we know what size device to be using, what size arteries? So we do have some data from the pediatric stroke group from Vanderbilt who measured imaging in anterior and posterior circulation across ages in 54 children who are healthy. So these are children without stroke, without vasculopathy. What they found was that from about the newborn period to 5 years, there is a really rapid linear growth in the size of the arteries. And by about 5 years, the cervical and cranial lumen diameters are approximating adult size. And so the question of safety and feasibility, I think, is a moving target as there are newer and smaller devices that are continually coming out. But I would suggest that there probably is reason to have some caution in the youngest age groups. I think a second big issue that is important to consider is that etiology of stroke in children is quite different than etiology of stroke in adults. And that seems to be something that's obvious, but I think that when you're thinking about pediatric patient selection for thrombectomy, stroke etiology matters in a way that it might not matter as much in adult stroke. A large vessel occlusion is not necessarily the same as a large vessel occlusion. So about 30 to 40% of pediatric stroke is due to cardioembolic disease. And this is what I would consider probably the real low-hanging fruit. This is where we should be starting when we're learning about who to approach for thrombectomy in children. So the growing number of children who are living with complex congenital heart disease at older and older ages, as our surgical techniques has gotten better, has also left us with a larger group of children who are at risk for a large vessel occlusion from their congenital heart disease at older ages. These children really are the ones who potentially could benefit from embolectomy the most. And I worry more about the 30 to 40% of children who present with stroke due to arteriopathic disease. These are the children with moya who have focal cerebral arteriopathy, which is thought to be inflammation of the vessel wall itself, and genetic arteriopathies. I'd worry much more about the fragility of vessels and thrombectomy in these patients. And the last consideration I'd like to offer you is really thinking about the patient selection in the extended time window, which is probably different for children compared to adults. In contrast to adults, children have very robust collaterals that initially might support brain tissue despite an LVO. And what this means clinically is they may present with low NIH stroke scale score or with fluctuating symptoms. And so the question of what to do and who to select when a patient looks good initially despite an LVO is an open one. And what I would suggest is that the same issue of really healthy collaterals probably affects imaging selection as well. We know that quantitative CT characterization of brain perfusion varies across childhood, and so our estimates of port infarct and penumbra may not be the same in children as it is in adults. So I know I'm leaving you with lots more questions than answers, but what I'd like to plug is that this is probably the real reason why we need ongoing collaboration between pediatric stroke neurologists and neurointerventional groups. And one thing I would offer, you may be wondering, who can I turn to? Who is my local pediatric stroke neurologist so that we can put together guidelines before a child shows up with a large vessel occlusion? And one suggestion is to turn to the International Pediatric Stroke Organization. This is a new foundation which was really founded in order to bridge the gap between groups of people who are treating pediatric stroke. If you use your phone, you should be able to take a picture of this QR code, and it can take you directly to the website. And I really am hopeful that I'm going to see many of you in the future as we work together to build collaboration to help children with cerebrovascular disease.